So it's called rheumatoid factor, okay? I just have to get through this. Okay. So the abnormal IgG is known as rheumatoid factor. So one of the labs you should have had on your sheet when you had rheumatoid arthritis was an RF titer, okay? So this forms an immune complex, all right? So it forms this immune complex. And guess what these immune complexes do? Okay, so basically what these immune complexes do, first of all, is they release something. What do they release? Okay, histamine, or what we call chemical mediators. So I look at it all as just being a chemical mediator. So histamine, bradykinin, and that kind of stuff. So they release chemical mediators, and these chemical mediators are pro-inflammatory. Okay, what do I mean by pro-inflammatory? They cause inflammation. Okay, they cause inflammation. So these immune complexes release these chemical mediators, all right? Those chemical mediators are pro-inflammatory. So it means it's going to cause what? Okay, so then what I'm going to have is now I'm going to have inflammation. All right, and then what's the inflammation going to affect? What's it going to affect? Okay, the synovial fluid or the synovial membrane, right? So it's going to affect the synovial fluid or the synovial membrane. Okay, synovial fluid or the synovial membrane. Now, it says pannus formation. Did any of you guys have that in your pathophys?
Thick synovial fluid.
Okay, well, it's not really thick synovial fluid. Correct. It's highly vascular tissue. Okay, that is not good tissue. It's tissue that forms that causes bone destruction. Hence, the joints get destroyed. Okay, so this then causes joint destruction. So when you look at this picture here, okay, because I can't draw, so bear with me. Okay, so when you look at this picture here, remember it's autoimmune and it causes the formation of an antigen. That antigen says to IgG, too bad, I know you're the good guy, but I'm going to join with you and make you abnormal now and make you sort of a bad guy. And now we're going to be called rheumatoid factor. All right? So now we're going to be called rheumatoid factor, and now we're going to release these substances into the bloodstream that's going to cause inflammation. The main place it causes inflammation is in the joints. Okay? So it's going to cause inflammation in the joints. Eventually this pannus is going to form. This pannus forms on this bone, and I'll draw it in here in a second, and it causes the joint to be destroyed. So if this part of the joint is destroyed, that joint's going to lean like this, isn't it? You see what I'm saying? So it's going to cause some joint destruction. So when you look at this picture here, okay, your synovial membrane lines the joint. Again, I can't draw it all because I don't have enough colors. So what you're going to get is you're going to get inflammation here of your synovial membrane. Okay, I'm just going to try to do it like this. So you get inflammation of your synovial membrane. Okay, so that's how it starts out, is with inflammation. All right, so you get inflammation of your synovial membrane. Okay, and then what's going to happen over time is that on this bone, I can't find my green, but on this bone, what's going to happen over time is then what happens to this synovial fluid? What do you think happens to the synovial fluid in here? You what? It gets really thick, okay? Synovial fluid is like grease. It lubricates. okay? But because of this chronic inflammation, that synovial fluid gets thick, all right? And so think of an egg white, okay? Think of an egg white versus water. So it gets very thick like that. So the synovial fluid gets thick, okay, like an egg white. And the purpose of your synovial fluid is so that your joints move, okay? So think about mobility now that this synovial fluid is getting thicker and now my joint's getting inflamed. What do you think you're going to see in this patient already? Well, not yet. We don't have bone destruction. I said we have inflammation, swelling, joint pain, redness. There you go. Didn't have to memorize a thing, did I? Pathophysiology. So on your sheets for your patients, when you give me report, there better be something about that. You see what I'm saying? That's how I wanted you to start thinking. Understand this. The head to toe assessment sheet isn't a problem. Okay? If you don't understand this, you're going to have a problem with the worksheet. Does that make sense? So this is how I wanted you to start thinking. Okay? So the synovial fluid gets thick. It gets like an egg white. All right? So it's a lot more difficult to move the joint. Then you get the synovial membrane being inflamed. And then what's going to happen is you're going to get the formation of this pannus. And pannus is highly vascular tissue that forms, but the problem with this is that it's composed of inflammatory cells. So this pannus that forms, they don't know why it forms, but it is composed of inflammatory cells. And so what that pannus is going to do is it's going to form, okay? I'm just putting it there, okay? So that's going to form, and then what's going to happen is this is going to start eating away at the bone, all right? So that's how you get the joint destruction. Not only do you get joint destruction, you get joint what? Deformity, all right? So you also get joint deformity. So that is what's happening, okay? And what's going to happen then is it's going to cause this joint, especially you see it wear a lot, right? The hands. And that's how you see, if you look at the pictures, why you're seeing the different deviations that you're seeing or those different deformities. It's going to depend on where in that joint this is happening, okay? Does that make sense? We okay with that? So see how you have to dig this out? Your book's patho is not that good, so what should you have done? Go somewhere else and look it up, okay? Google pathophysiology of rheumatoid arthritis. You got to use your resources, okay? You have to use your resources because your book is not very good in relationship to the patho for rheumatoid arthritis, okay? So that's actually what's going on in the joints when you talk about rheumatoid arthritis. So you end up actually potentially having some joint destruction. There's other things that are going to go on that we're going to talk about in a minute, okay? So if you like that, like pretty pictures, see, not my picture. This is another picture here. So this is your normal joint, okay? This is your normal joint. This is the synovial membrane here that lines the joint. This is the cartilage of the joint. So this is what a normal joint looks like, okay? So then the first thing that happens is this synovial membrane, okay, which is this little white part here, gets inflamed, hence it's all red, okay? You see that? And then over time, this pannus starts to form, which is right here on this bone. And remember, it's highly vascular tissue that contains inflammatory cells. So over time, these inflammatory cells, right, little Pac-Man, they eat the bone. So they start eating the bone, and then you have bone loss. Okay, you see that? So then wherever this is happening, you end up having bone loss and bone destruction. So that's what's happening in your joint with rheumatoid arthritis. So just knowing that ought to trigger what kind of thoughts in your head with this patient without even going any farther. What would you think about this?
Mobility.
Big concepts, big rocks, mobility, safety, pain, right? Do you see what I'm doing? That's how you have to start thinking. So my focused assessment will be on the joints, right? But in the back of my head now, I have to think about pain. I have to think about safety and mobility, right? And there's other things we'll think about in a second. So this is just showing you what's going to happen over time in the joints, okay? So pathophys should just be linear. Autoimmune, antigen, abnormal IgG, okay? Chemical mediators, inflammation, pannus, joint destruction. Should have just been in a line on your sheet like that, okay? That's how you have to think about it. All right, so concept map. I don't want to keep flicking back and forth between the dot cam because it doesn't work. If I do that, it's too much. All right, so let's then think about, okay, so the medical diagnosis was rheumatoid arthritis, correct? All right, we have the brief pathophysiology. Now we're going over to assessment, okay? So if I have to do an assessment on this patient, what did we say? What do you guys have for assessment on your concept map?
It says pain level.
Pardon me?
I just said assess pain level.
Okay, pain. What else do we got to think about first, though?
Safety.
Okay, safety. What else? Okay, before range of motion. What if you walk into this patient's room? Picture this patient. What would your patient look like? So we would have pain. The pain would be what? Remember, it's a symmetrical disease process, right? What other assessment data would you have? We already talked about it. Joint what? Swelling. Okay. Okay, deformity. We could have a deformity down here. Okay. There. Why are you even having a hard time thinking about that? You learned about inflammation. You already know inflammation causes redness, swelling, and pain. That should have been right in your head right away. Shouldn't even have had to think about it. That's just a given. Have you ever taken care of a cellulitis patient? What is their leg like when you touch it? Oh, what else does their leg look like? It's red or discolored, it's swollen. It doesn't matter. It's inflammation. Redness, swelling, pain, instant, okay? So that's one of the things you want to think about, okay? Okay. Stiffness. Did you think about stiffness? Okay. So tell me about the stiffness.
Early AM works.
Okay. Stiffness should have been on your sheet. Early AM. Okay.
Last an hour or more.
Okay. It usually lasts longer. With osteoarthritis, if you get up and move around, right, the pain usually subsides. With rheumatoid, guess what? It's there. Okay. You get up in the morning, I'm moving around, and it's not going away, it's not going away, it's not going away. And the duration of the morning stiffness that you have with rheumatoid arthritis is a huge factor when you think about the disease activity and what it's doing in the body, right? So if this is really severe, okay? So let's say my stiffness is lasting 4 hours. 5 hours. What's it telling me about what's going on in here?
Yeah, the inflammation.
It's pretty bad, right? It's
Yeah.
pretty bad. Because I'm still hurting 5 and 6 hours later pretty bad. So the longer the joint stiffness and pain, the worse, okay, the disease activity in the body. All right? So that's one of the things that you need to think about, okay? So remember, joint involvement is bilateral, symmetrical. All right, with rheumatoid. That is one of the things that differentiates it from osteoarthritis that you had in 240, okay?
With that picture down there though, they'd still have rheumatoid arthritis in the other knee, it just isn't healthy.
Right, all this is showing you is what a normal knee looks like. It's just a compare and contrast. This says normal, this says affected. So all they're saying is this is normal. Then if you look up in here, and you can tap it and feel it, okay? They have fluid up in here. So both would look like that, but they're only doing a comparison here. And these are the joints that are most commonly affected. Look at them all, right? All of them, correct? What is subluxation?
Or past each other.
Okay, when it slips out of place. What am I most concerned about subluxation?
Fall.
Where in the body?
Good.
Which spine?
Cervical.
My cervical, absolutely. Why am I worried about subluxation in the cervical spine? What is there? You're breathing, right? Everything, your whole body, okay? 1, 2, 3, cervical 1, 2, 3 probably. Okay? So when you're doing this reading, this is how you're supposed to be getting information from your reading. You need to stop and you need to think about it. What does this word subluxation mean? Okay, it means the joints, right, go over one another. So if I have my cervical spine, right, and they're supposed to be like this and now they're doing this, and I have bone destruction, it can be pinching on what? Those nerves in there, right? The spinal column, those nerves, I can quit breathing. I can become quadriplegic. So it's critical. See, that's what I'm telling you. You can't just go in and say, yeah, they have swelling of the joints and redness. Here's your pill. I'm going on to my next patient. That's not nursing. I can teach my dog to go in there and do that. Literally. You know what I'm saying? I don't mean that disrespectfully, but you can teach anybody to go in there and do that. That's not thinking. Thinking is this person, I got to worry about all these other things that can be wrong with this patient. That's a good nurse. That's an excellent nurse. Where you're sitting there, you're thinking about all these other things that can go wrong. So now I got to worry about, okay, are they complaining of neck pain? You know, I mean, are they having any trouble breathing? Are they complaining a little bit more about movement than they would normally? Are they having difficulty lifting their arms? Do you know what I'm saying? That's the kind of thing you got to think about. You don't always have to ask them. You can watch them, okay? Why are you checking somebody's pupils when you go in and have a conversation with them? And they can talk to me. Why are you checking their pupils? Why are you doing that to the patient? Tell me why you do that. But I know the baseline. You could see that. But they're alert and oriented and they're talking to me. And they're making sense and I'm having a conversation. Do I need to do that? Absolutely. See what I'm saying? However, if they come in and they've had an aneurysm in the past, right? Or they've had brain cancer in the past, see where I'm going? Then I might want to do that. But I'm having a normal conversation. Why am I shining a flashlight in their eyes, for gosh sakes? If you did that to me, I'd tell you, I'd take the flashlight out of your hand. I literally would take it out of your hand and ask you, why are you doing that? I'm normal, okay? I have no psych history. I have no neuro history. Why are you shining a light in my eyes? I didn't fall and hit my head. So you're not worried about a brain bleed. Why are you doing that? I'm having a conversation with you. That's 250. Don't be, this is what I learned in fundamentals, and so I have to do this. It makes no sense for you to do that to me because you're having a normal conversation.
Yeah, but don't you have to chart that you do it? So we would-
I can look at your pupils right now. No, I don't. I can look at your pupils and they're the same size. And I can tell you what size your pupils are. And I don't even have to shine a flashlight in there. And when I'm moving around the room, you're tracking and focusing. I don't have to go like this and have you do that. Hello. I'm just trying to tell you the real world. My students, get ready for the real world. Because it's coming. Look at them shaking now. Look, they're already talking. Two of them are talking. They're separating. Okay? I'm just trying to give you reality. You know, I'm giving you reality. Why are you doing things you don't need to do? If you understand your patient and you understand the comorbidities that they have, then you know what you need to do. That's 250. Okay? When you have 5 and 6 patients, I don't have time to be going in there and shining a flashlight in everybody's eyes. Okay? If I know they're getting up and go to the bathroom, and they're not a fall risk, do I have to have them squeeze my hands and push on their feet? No, they're getting up by themselves. Why are you doing that? Do you understand what I'm saying? So put it all in perspective of what's going on. You learned it, now you just do it for no reason. Okay? I can tell what color they are. I'm looking at them. I can tell if they're having trouble breathing because I'm looking at them. Okay? You should be able to walk in a room and within 60 seconds be able to come out and tell me what's going on with your patient. I know if they have a Foley, right? You should have looked, you walked in the room. What color was the urine? Okay. Do they have an IV? Where's the IV? What's the site look like? What fluid's hanging? What's it running at? What's their color? Do they have oxygen on? Don't they have oxygen on? Are they having trouble breathing or they're not having trouble breathing? Do they have a chest tube or don't they have a chest tube? 60 seconds, right? You should be able to walk around the bed and know all that. When you talk to your patient, hi, I'm Paul, I'm your nurse for today, and I'm walking around the bed and I'm looking and observing all that when I introduce myself. I already got their neuro assessment, I already know their color, I already know they're not having any trouble breathing. There's no oxygen on, I know they got D5 going. See what I'm telling you? That's 250. You don't have time to have your little worksheet out and try to figure out everything you need to do. You need to use this now, okay? Your worksheet is for overall management, okay? So you should be able to think about this rheumatoid arthritis patient and already know, if you know this, right? I know I'm gonna get to joint destruction and deformity, right? I know I have inflammation. I already know what inflammation causes, right? Redness, swelling, pain. So how bad is this rheumatoid arthritis? Well, let me look at their joints a little bit more, right? See what's going on. Does that make sense? Am I making sense? Because I know I say a lot of things like that, but I want you to understand the difference between 240 and 250. So that's why I'm trying to get you to think about things in a completely different way, okay? All right? I'm not going to read this slide. Here's the joints that are affected. Well, hello. I mean, everything but your brain and your pelvis, basically, right, is affected with rheumatoid arthritis, okay? This is a picture. Do you have this on your sheets anywhere, your concept map sheet? Okay, where do you have this? Do you have a potential or actual complication section? Down in the middle center somewhere? Okay, did you put any of these there on your concept map? Yes, I hear a yes. So what did you put down in there? In the very center of your concept map at the bottom, it says actual or potential complications. Well, it can be this too, okay? It says physiological adaptation, so this is physiological, okay? Okay. So ulnar drift, okay? So where's your ulnar side? You all better know this. Point to your ulnar side for me. Please be correct. Not your pinky. Your ulnar side. She's holding up her little pinky. That's her ulnar side. So, okay, we got to help her, okay? Ulnar, right? So what's happening here is these joints right in here are being affected by the rheumatoid arthritis. And what's happening is it's causing the joint to deviate this way, okay? Because things are shortening in here. Things that hold the bones to the joints, because the joints are being destroyed, are shortening. So it's pulling the joint that way. So ulnar deviation. So right away, what do I think about? What do I think about ulnar deviation? Boutonniere, isn't that tough? Isn't that a tough one? Lots of joints are being destroyed there, aren't they? Boutonniere deformity, okay? And then your swan neck deformity, okay? I found this picture afterwards and added it because, see, it really looks like a swan here, doesn't it? So this is what's happening to this joint, okay? And look what's happening, all right? This person has a boutonniere deformity of the thumb. Look at, they've got ulnar deviation and swan neck. This is showing all of them. So if I walked in my room and I saw this in the patient, what would you think about? Hmm? Yeah, how are they going to take care of themselves? How are they going to brush their teeth? Comb their hair? Bathe? Oh yeah, open up a bottle, especially the prescription bottles. Yeah, what did you guys have? Their rheumatoid arthritis patient had a colostomy. How's this patient going to change that ostomy bag at home? See why I threw that in there?
They live alone.
They live alone and they have an ostomy. See what I'm trying to get you to do? So they live alone and they have an ostomy. So how are we gonna modify? How are we gonna help them? Okay, figure out how to change this bag. Does that make sense? Do you see what I'm saying? You can't just go in there and think about this patient has these joint deformities. How are these joint deformities affecting their activity of daily living? Okay? How can they open things? How can they hold spoons? Right? Which we'll get to who we're gonna call in a little while. But just see what I'm saying right away. I think to myself, safety. I think about how are they gonna take care of themselves, right? We take for granted because we can. But the minute you can't is when you really understand what that person's going through. Okay? So these are some of the things that you schedules look like. Okay? So they can break down and they can cause the patient to get an infection. And we're going to talk about chronic inflammation. What does chronic inflammation do to some of your labs over time? What labs do chronic inflammation affect? What main labs?
ERP and ESR.
Okay, those are elevated. Okay. ESR tends to be more localized inflammation. CRP tends to be more indicator of systemic inflammation. But chronic inflammation over time decreases what?
Would increase your white blood cell count initially, right?
Well, it would increase your white blood cell count, so it what is it gonna decrease then? You got it, your red blood cells, and these people become anemic because chronic inflammation over time leads to anemia, okay? So when you do a red blood cell count, you're not gonna call the doctor. This is what I love, I can't wait to get into this, but what else did you have wrong with your patient over here? What was wrong with your rheumatoid patient over here?
Osteoporosis,
Yeah.
dermatitis, anemia,
Fractures.
Uh-huh, but what else did they have?
chronic
Oh,
inflammation.
They had a fistula. So the question to me was, do we put them on tele or not tele either, right? And I said, well, I don't know that, because what's going on with your patient? Okay, are they tachycardia, are they not tachycardic? And so when you think about this patient that has renal failure, okay, I said to them, what's their potassium? I said 5.6. Are you gonna call the doctor? What did you say? I said, oh, she freaked. I said, I wouldn't necessarily call the doctor on a 5.6 potassium. Why not? What do they have?
Chronic.
Chronic renal failure. It's normal that it's gonna be elevated. If they're asymptomatic, I don't worry about it, because what are they gonna have? Dialysis. So that's why they don't draw labs every day on your chronic renal failure patients, because they know they're going to be abnormal. Your chronic renal failure patient, right? So is the insurance going to pay for tele on that patient? Not if they're asymptomatic. You see how I'm thinking? So just because it's abnormal doesn't mean you have to panic, right? And call the doctor. That's what you got to learn this semester. Okay, that's what you got to learn. The students always say, I'm going to call the doctor. The potassium's 5.2. I said, have fun. I'm leaving. When you talk to them, see you later. Call me and tell me how it went.
So,
Hmm?
if their levels come back and it's like a critical and they're chronic renal failure, they're gonna have dialysis that day, you still have to call if it's a critical result, you're supposed to call.
You always call if it's a critical result, because that's the policy within the institution. Okay? If they're having dialysis that day and they're not symptomatic, they won't do anything. Okay? But if they're not having dialysis and the dialysis really didn't help as well as it should, they may give them something to lower it if it's way up there, like 8, 9, whatever. Yeah. But that's what you got to learn. See, that's what you got to learn. So, are you going to call somebody? If you know that inflammation causes anemia, all right, so what are you going to do? So this rheumatoid patient, you drew their labs and their hemoglobin was 8.6. You going to call the doctor? Tell me just your gut, what would you do right now without thinking? Would you call the doctor? No.
I got previous labs and maybe see if we can order some iron.
Okay, see what she just said to me? What is she doing with the labs? What's that word? I'm trending the labs. Okay, if that was 8.2 yesterday, now it's 8.6, or if it was 9 and now it's 8.6, are you going to panic? Is the patient breathing okay? Do you see what I'm saying? That's 250. All right? Because all you've learned is this is an abnormal lab, I got to call the doctor. Is the patient symptomatic? Are they having problems? If they're not having problems, why are you panicking on it? Do you understand what I'm saying? So that's kind of what you have to learn, okay? All right, so Sojourn's syndrome. Okay, did you guys have that down on your sheets from home? I know Dana didn't. He already said no. Right, he even smiling, so he's being honest. At least he's honest. Thank you for your honesty. I didn't expect you to go into detail. I'm just giving you an example of what's going to be expected in the future. You won't have 3 of them next time. You'll have 1. So, did you have that down anywhere? Sojourn syndrome, you did? Did these ladies here? No, you didn't have that down for rheumatoid? Okay. So, why is that even in here with rheumatoid arthritis? What's floating around in my body? What's floating around in my body? What's floating around in my body? Immune complexes. They can deposit themselves anywhere in the body. Okay? You have a little picture, right, in your textbook. I don't know what page because I have the new edition, but on page 1527 it shows all the different things that can happen to this person with rheumatoid arthritis. So you have all these little immune complexes floating around and they just decide they're going to the eye. Okay? That's all Sojourn syndrome is. So it's another complication of rheumatoid arthritis. But you know how it says extra articular? Means outside of the what? Joint. Okay? So basically what they tend to do is they tend to obstruct the glands. Okay? So you can't like secrete tears and your eyes get extremely dry. Because did you not have something in your bags? You had stuff for dry eyes in your bags, didn't you, for rheumatoid arthritis? You had like moistening eye drops, right? Okay. All right. So think about when your eyes really get dry. Does anybody have allergies? Does it ever bother your eyes? Tell me how your eyes get. You feel like you got sandpaper or grit in your eyes, huh? And you can't do anything about it, right? I have allergies too. I only had this happen one time. It was really bad. I've never had it happen before because I don't get the normal allergy. I get these big hives all over my body for whatever reason. You guys are young enough, you can outgrow them. He told me I'm too old. It's nice, you get old, everything falls apart. But anyway, painful. Painful, okay? So painful. So these eyes can really hurt. And what they'll usually do is give them some kind of an eye drop. Depending on how bad it is, it may just be a moistening eye drop, or it may be something with an antibiotic and a moisturizer in it, depending on how bad they are. So basically, I can't tear, right? I don't have tears. Those tears help keep your eyes clean, right? And then you become very photosensitive or light hurts your eyes because this is very painful, okay? And the problem is that within your eyes, you can get those immune complexes, but you can also get nodules in your eyes that form, and then they can cause retinal damage. You can have vision problems. So see, I'm talking about an arthritis patient, and now what else am I giving them? You know, they have all these other problems now that are happening because they have the arthritis. Here's some more things that can happen, right? Did you have those down? Did anybody have any of those down on your sheet? These kinds of extra-articular manifestations are more common in people with long-standing, okay, rheumatoid arthritis. So they've had the disease for a longer period of time versus somebody who's newly diagnosed. You're not going to see these basically in newly diagnosed patients, okay? They have it something called Felty syndrome. They see it in people with long-standing severe rheumatoid arthritis. They're not really sure exactly what causes this, okay? Not everybody has this that has rheumatoid arthritis, but again, those people that have a very high rheumatoid factor or rheumatoid titer tend to be the ones that get more of your extra articular manifestations, okay? So their spleen becomes enlarged, okay? Their white blood cell count drops. And so my concern, you already know what my concern is with the white blood cell count dropping, right? Infection. Then I get these nodules in my lungs. What's that going to affect? Breathing. So right away, right, you should say, okay, I have to make sure what's this patient's color, right? Are they having any trouble breathing? Is the shortness of breath at rest? Is it upon exertion? What's their O2 sat, right? Saturation, guys, not stats. Stats is a math class. Okay, it's called saturation. It's spelled S-A-T. So when you're talking about O2 sats, do not say O2 stats to your people when you're giving a report. Because it's not a stat, it's a saturation. It's O2 sats, okay? What is their oxygen saturation, okay? Are they having trouble breathing? Those kinds of things you have to think about. Do we need a chest x-ray on this patient, right? Make sense? Okay, so that's just something that you see. All right, now here's a bunch of other signs and symptoms that you should put under assessment in the top left, right? Did we have any of these besides these in the top left? That's okay, this says assessment. This is assessment, so it's the top left box, right? So the joint pain, the joint swelling, the joint redness, fatigue, weakness, stiffness, right? Why do they have all this stuff? Why is all this happening? Your body is working hard, right? This is an autoimmune disease process. Your body is working hard. All right, so number one, I have generalized weakness and stiffness, right? Because what's going on in my joints? Pathophys, okay? Fever, what's going on in my body? Low-grade fever, what's a low-grade fever? Below what? 101, probably, below 101. Okay, 100.5 to me is low-grade fever. 100.8 is a low-grade fever. Lymph nodes, what's my lymph nodes do? What's in there? What's in my lymph nodes? Do that and I gotta drink water. Show me it's gone by 3 o'clock. God, I can start drinking, guys. Hang on. Gotta chug. I hate water. God, can't you tell? Yuck. It's worse when it's warm. Oh, I try to be, but it's awful, isn't it? Yes, it does. It tastes like bleach.
Huh?
So what kind of water are you taking?
City water. I got normal water, not well water, and well water is awful. I can't even swallow it. Ugh. All right, so lymph nodes. What are your lymph nodes? Why do they get enlarged? They're filtering out all this stuff, right? So they get enlarged. So you get lymph node enlargement, okay? Fatigue, generalized weakness, anorexia. Why do I have these two things? I just plain don't feel good, right? You don't feel good, so you don't eat, you lose weight, okay? Yeah. Yeah. How do you even get to the store? How do you drive? You know, think about that. All right? Perfect. Yeah. Oh, yeah, I forgot about that. I don't want somebody else picking out my food.
I mean, I don't either.
Huh?
They might not have the dexterity to order it on the phone.
That's true. They might not have the dexterity to put the order. You're right. You're absolutely right. You know? Yeah. So here's some more symptoms. Subcutaneous nodules we already talked about, right? Okay, then we have vasculitis. What's vasculitis? Okay, and they're showing it in the eye here. Look at that eye. Okay, so it's inflammation of the blood vessels, okay? And so the complexes are, and look at the shape of the pupil. Did anybody notice that or just me? Look at the shape of the pupil because of the immune complexes that are affecting that eye. So it affects the shape of that pupil, okay? Peripheral neuropathy, okay? Why would peripheral neuropathy occur?
I feel like it could be because the nodules or deformities are affecting the nerves, right?
Nerves, and they can decrease blood flow, right? They can decrease blood flow. So we end up with peripheral neuropathy. Respiratory, we already know, right? The complexes go in my lungs and they block things, makes it harder for me. Cardiac complications, what does your book show can happen to your heart? Okay? Kind of lots of stuff. Inflammation of the pericardium or the pericardial sac, right? And if you get fluid building up in that pericardial sac, what happens to your heart? You've had pericarditis already. Squeezes in, right? So then what does it decrease? Cardiac output. My whole body's affected now. Head to toe, whole body's affected. Eye involvement, and we already talked about anemia, right? So chronic inflammation leads to anemia. There's again. Okay, did you have these down for diagnostic tests? Where's my people? Okay, my rheumatoid people, tell me about these diagnostic tests. Rheumatoid factor, we already mentioned, right? Rheumatoid factor, correct? Okay, we already know that rheumatoid factor, right? It attaches to the good IgG and forms that immune complex. We already know that, okay? Okay, well, let's stay up here. Don't get away from the tough ones. You guys want to run down to the simple ones, but that's not the ones you're going to be tested on, are you? Simplicity. So your labs and diagnostic tests, right? What is anti-nuclear antibody? Pardon me? Okay, well, when we talk about anti-nuclear antibody, we're already talking about what part of my cell? The nucleus of the cell. So we're already talking about the nucleus of the cell. So when you're talking about this, a positive ANA, right? What's your tissues composed of? Cells. So this is autoimmune. So if it destroys your joints and your tissues, right, it can affect tissues. So what is it destroying? The cell. Okay? It's destroying the cell. So anti-nuclear antibody. So basically it indicates that your immune system, okay, your immune system has launched an attack against the tissues of your body. So basically it's an autoimmune reaction. So you've got cells, you've got tissues, you've got organs, you've got the person, right? So you've got cells, tissues, organs, person. So the cells are being destroyed. However, if it's positive, you need to do further testing, okay? Because an ANA is also positive in what diagnosis? Lupus, right? So early on, how do I know if they have lupus or how do I know if they have rheumatoid arthritis, right? So it's also positive there. This is, ANA is usually negative until later on in the disease because it's not until you get like a full-blown arthritis that you start seeing some of these, okay? All right, so what is the anti-cyclic citrullinated protein antibody or anti-CCP? What is that? It's in your book. So I'm going to draw this lab. Okay, I'm going to draw this lab. And what is this lab telling me? A normal level is usually less than 20. Okay, so if this level is higher, what is it telling me? It's in your book. I'm looking at it right here on page 1527. It's right in your book, so you should have had this on your sheet. It's important in the diagnosis of rheumatoid arthritis. Okay? Oh, and so here's all the, on page 1528, the joint involvement, the testing, the duration. I love these little things that are in pink because they have all kinds of information in them, right? So did you have that as a lab, my rheumatoid people? Yes, no, maybe so? No? You didn't put that one down? Anybody put it down from filling out your concept map?
I put it down, but I didn't look up what it was.
Okay, you didn't look up what it was, okay? But you put it down, okay? So basically it is an antibody that is found in patients that have rheumatoid arthritis, okay? A level greater than 20 suggests a high probability that the patient has rheumatoid arthritis. So this is kind of a specific test versus the ANA. This is a more specific test for rheumatoid arthritis, okay?
Do the old books not have that?
I have no idea.
It doesn't have very much about it. And
It only has like 2 lines.
Yeah, it says that it's more specific than rheumatoid factor,
Correct,
and it may be good for testing in early cases.
correct. More than late cases,
What
yep.
page are you on that for?
That one in the new book is on 1527.
Yeah, I don't know the old book. You just have to look it up in the index.
Just trying to.
Yeah.
1572,
1572. So the higher the levels of this antibody, the more likely the patient has rheumatoid arthritis. So this is more specific to rheumatoid than the ANA, okay? Because the ANA is found in other disease processes. Did you have serum complement down? What's serum complement? I know you've had it because I've seen that your lab slips. What is a serum complement? So complement is a group of antibodies, okay? Complement is basically a group of proteins or a group of antibodies, okay, that work with your immune system to fight off disease or fight off pathogens, okay? So when you have something going on in your body that's infectious, right? Any kind of inflammatory process, basically, what happens is the complement system is activated and it's sort of like, come help me, all right? I need some help. I have something going on. I need to recruit somebody to try to help me. And what they try to do is it tries to help get rid of these complexes that are causing the problems, okay? So they will draw what we call serum complement levels. And when they draw that, the serum complement level will be increased because I'm going to have more of it because I've recruited it to help me fight off some of these immune complexes. So the serum complement level will be elevated. So it helps the immune system, okay, to help fight off some of the infection, okay. ESR, CRP, we already talked about. We already talked about the CBC, okay. Synovial fluid analysis, okay. What will it show? Okay, it may show the rheumatoid factor. What else may be in the synovial fluid? Because exactly, it's inflammatory. So there may be some white blood cells within that synovial fluid, okay? So they may do a synovial fluid analysis. What did you have down for diagnostic tests? Where's my rheumatoid people? What did you have down for diagnostic tests on your concept map? Anybody? Okay, x-rays. Okay, CT. Where are we going to tend to do the CT more of? The neck, right? Because I want to make sure there's no subluxation there, okay? So that's where I really want to do a CT. X-rays, right, are going to show what? The joint deformities, right? So x-rays are really good for bone or a chest x-ray or PICC line placement or NG tube placement. Otherwise, they're worthless, okay? They're worthless. You need a CT or an MRI. The problem is insurances make you go from A to B to C to D. That's what happens, okay? What else might you have? Okay, a biopsy. Yeah, what are you going to biopsy? A biopsy. Well, you wouldn't really, yeah, you kind of, it's not really a biopsy of the synovial fluid because it's a fluid. So if you do a synovial fluid, it's a synovial fluid analysis where they're just looking to see if there's any white blood cells or something. This is more of the nodules to see what's in those actual nodules, okay? So you can do biopsies, okay? Make sense, right? Good with that? You had all that down? Big rocks. All right, so when you're looking at this concept map, okay, and we're actually looking at some of the big rocks now. These are the main things that you're trying to do. What does functional status mean? When I talk about functional status, what am I talking about? Everything that they can do, right? What are you able to do? What are you not able to do? Okay? So that's what we're looking at. So what can they do? What can't they do? And we're trying to prevent disability. That's the overall and what we're trying to prevent. So let's look at medications. Okay. Did you have NSAIDs down on your sheet? Under medications? Why would I give an NSAID to this patient? Okay, inflammation. Okay. I will tell you, medications are the cornerstone treatment for somebody with rheumatoid arthritis. This is the main thing that we do to treat this disease process. So NSAIDs are one of those classifications of medications. Okay, how do they work? Okay, so they basically work by blocking an enzyme, right? An enzyme that promotes inflammation. So NSAIDs. So what else do we know about NSAIDs?
Monitor kidney function,
Okay, we want to monitor renal function.
blood pressure,
Okay, why do I want to worry about blood pressure?
just gonna be an indicator,
Of what?
fluid retention.
Okay, can NSAIDs cause fluid retention? I'm asking you, not me. Isn't that interesting? This will be a fun test, right? Okay, NSAIDs. What do you know about NSAIDs?
Non-steroid.
Non-steroidal anti-inflammatories.
GI.
GI upset, huge with NSAIDs, right? NSAIDs. Pardon me? Ulcers. So we're here. Here's how you got to think again. Okay, this is mild rheumatoid arthritis. Bleeding. So right away, I'm taking care of this patient. I have a long-standing history of rheumatoid arthritis. Luckily, it's still in the mild form, and I'm on NSAIDs. They come into the hospital, and what do you have to think about?
How they've been taking their NSAIDs, if they've been taking regular or they've been abusing them. Do
Okay,
they
but
have
what are our
ulcers?
concerns with NSAIDs?
GI.
Okay, I'm concerned with GI bleed, so tell me what you're gonna have to think about with this patient. Okay, anything that shows the potential of a bleed. What is their blood pressure? What is their heart rate? What's their heart rate gonna do if they have a bleed? It's gonna go up. They're tachycardic. Why? Okay, always tell me why. You gotta understand why, or you might as well take it off your sheet, because you don't understand it. It's trying to compensate, right? It's trying to compensate. Say, oh my gosh, you don't have enough volume, you don't have enough oxygen, so if I beat faster, I'm gonna help you, but no, you're not, because I have decreased cardiac output, okay? So the blood pressure may be low, the heart rate may be high. What about my respiratory rate? Probably high, because what am I trying to do? I don't have enough oxygen. So what's the lungs do? They try to compensate, right? By breathing faster to try to get it. But if the volume's not there from the heart, what good is it going to do, right? Understand what I'm saying? Okay. So then you want to make sure you look at bowel movements, right? If they have any emesis, do they have any bleed? Okay. So you need to look at some of the GI side effects that they can have with these. Okay. So they could become anemic, right? Because they could lose volume if they have a GI bleed. They can have stomach pain, right? Some of those kinds of things. Okay? So basically, this is what you have to understand, and you have to teach these patients about meds for arthritis. They don't work overnight. Some of your DMARDs can take months before they start working. So these patients tend to be non-compliant with their medications, okay? So under medications, you need to have NSAIDs. NSAIDs are for mild rheumatoid arthritis, okay? The biggest concern is the GI side effects. The other thing that NSAIDs do is they inhibit platelet function, okay? And if they inhibit platelet function, what can they cause? Bleeding, okay? So platelet counts I want to look at. I want to look at a CBC, right, in these patients, okay? They can cause some problems with kidneys, like Kyle said. So I want to make sure they have good intake and output. I want to make sure their breath sounds are clear. I want to make sure they don't have any edema, right? I want to make sure their heart rate's not high, because if I'm volume overload, I'm tachycardic, right? You see what I'm doing? What's their intake and output? Am I making sense? That's how you have to think about things, okay? That's how you have to think about things with patients on these medications, okay? So fluid retention is a problem with patients with NSAIDs, as Kyle mentioned, but nobody wanted to validate it for him, okay? Renal function, all right? So some of those things that you have to think about. So what could we do for this patient? I got to take this NSAID because it really seems to be helping.
Co-ops too.
Pardon me? Okay, give them something for the stomach at the same time. Maybe a protein pump inhibitor or some kind of anti-ulcer kind of medication, Carafate, whatever the doctor wants to give them to help prevent the, the breakdown of the lining, okay, of the stomach, okay? All right. Did you have corticosteroids down? Everybody should have had this on their sheet, right? Okay, corticosteroids, the good, the bad, and the ugly.
Shortest time, most dose.
Yep, low dose corticosteroids are the second best approach to treat a patient with rheumatoid arthritis, okay? Actually, evidence-based practice, and I wrote this down, so I gotta always read it so I give you the right stuff. Evidence-based practice suggests that low-dose corticosteroids, okay, may slow the development and progression of bone erosions associated with rheumatoid arthritis. Now that's good news. So it may prevent bone loss, okay? Okay, these should be used only for symptom control. Why should they be used only for symptom control? So this is when they have an exacerbation or a flare-up. Yeah, you ever look at the side effects of corticosteroids? How many have ever been on a corticosteroid? How do you feel? Oh my God.
I can't sleep at night.
Me either. I'm really anxious because I get put on them every time I have an allergic reaction. You know, I said, just give me a shot. I'm not taking these things because trouble breathing. I'm always having trouble breathing. I can't sleep. You're starving to death. You could eat a 10-course meal and 15 minutes later you want another 10-course meal. You're starving. You just don't feel good. They can lead to GI bleeding. They elevate your blood glucose levels. Hence, as a nurse taking care of this patient, a nursing intervention would be to monitor blood sugar levels. See what I'm doing? Okay? I'm in here with rheumatoid arthritis and I'm on corticosteroids and you think I'm diabetic? No, you're not diabetic, but they do elevate blood sugar levels. I need to monitor your blood sugar. See how I want you to think? Okay? That's how I want you to start thinking, all right, when you're taking care of these people. I'm not going through all the long-term effects. You've had these already. That's a 240 content, okay? So basically, the main issue with corticosteroids is due to the fact that they have numerous complications. And what do you got to think about with corticosteroids? Pardon? Weight gain, yeah, ooh, yeah, because you eat every 10 minutes. But what do you got to do with corticosteroids? Taper them off, because what's not working? Yeah, because your adrenal glands are the ones that normally produce these, right? But what I'm giving you, when I'm pumping your body full of them, the adrenal glands can take a nap. So they take a nap for too long, guess what? They want to stay there, okay? They don't want to wake up. So when you start taking them off these, you can't abruptly stop these because you've got to slowly wean them down so you can tickle that adrenal gland and say, wake up, okay? I need you to start working for me again, okay? The other thing they really is bad is osteoporosis. So if people are on these for any length of time or they have a lot of exacerbations where they keep putting them on, they always think about a calcium supplement. So calcium should have been a medicine on your sheet too for these patients, okay? I'm not going to get into this good, bad, ugly. You already know the good, the bad, the ugly. Okay, DMARDs. Did you have DMARDs down? Yeah? Everybody better have had DMARDs down, right? Okay. So basically, joint changes they have found in the literature can happen within the first year of having rheumatoid arthritis. All right? So those changes can start occurring within 1 year. So basically, healthcare providers are now more aggressively prescribing the DMARDs because the other thing that DMARDs can do is right here's your evidence-based practice. Okay? Your corticosteroids can do that too, but now you have osteoporosis, right? Now you have elevated blood sugars, right? Now you have all the complications that you can get, the GI bleed, the poor wound healing, and whatever. So they start to use these, but look how long you got to take them before you know if they're working or not. So how would you feel as if you're a patient and you were put on a DMARD? 2 weeks later, still taking the pill. Yep. Still taking the pill. A month later, yep. No change, still taking the pill. What are you going to do over time? I'm not taking the pill. Quit taking the pill. Because it's not doing any good. Teaching on your sheet. Teaching. Okay, huge. Huge teaching. All right, patient teaching, bottom right-hand corner better have something about medications, okay? Okay. So these are extremely important medicines. All right, they target the immune system. So hopefully these patients, it will help. Now the one they tend to use the most is methotrexate. Methotrexate is also a cancer medication, but the reason they tend to use methotrexate is because it has a lower toxicity and it's cheap. Okay? One of the problems with people that have chronic diseases is the ability to what? Pay for their medications. Okay? However, since it also has anti-neoplastic properties, which is cancer med, it can cause bone marrow issues, right? So again, we need to think about bone marrow suppression in these patients. And if I have bone marrow suppression, then I have to worry about infection, right? So then now I'm worrying about infection in these people, okay? So bone marrow infection and hepatotoxicity tend to be more severe effects, okay? So if I have to monitor what labs then? Liver enzymes, okay? And what other ones? CBC, okay? CBC is critical, okay? CBC is critical, okay? So again, this is the one they tend to most often use, but I just listed other ones like hydroxychloroquine, sulfasalazine, penicillamine, and this one I never could say. Whatever, I still can't say it. But anyway, they won't be able to put it on this slide anyway because they won't be able to understand what I'm saying. So these are really good medications, okay? These are what they tend to use most often because now the data is showing that bone destruction is starting within 1 year, okay? You've heard of this one on TV, right? Yeah, man, that commercial. Everybody believes the commercial, okay? Let's believe the commercial. This is for moderate to severe rheumatoid arthritis. This is one of the newer classes of medications, and it's called a Janus kinase inhibitor. And basically, Janus kinase is like an enzyme that's released with inflammation, okay? And so basically what these drugs do is they block that enzyme that causes inflammation, okay? So that's basically what these medications do. So they do not use this as first-line therapy. This is basically used for patients who don't respond to like your methotrexates or your DMARDs. Then they'll try going to this classification of medication. So again, it's all about evaluating your patient, isn't it? What's the patient's response to what you're doing? That's what it's all about, right? Okay. BRMs, biological response modifiers. They're also called biologics, or it's also referred to, as it says up there, immunotherapy, okay? They can be used alone, or we can use them with patients who are on your DMARDs, okay? So again, they're used for moderate to severe rheumatoid arthritis. They are given to people who then therefore have had rheumatoid arthritis for a longer period of time. Okay, these aren't the first things that I'm going to give to my patients. We also use these for patients who, and I missed a word in here, this should be used for patients who have not responded to DMARDs. Okay, I just looked at that and said, oh, I missed something. They have not responded to DMARDs. So they may try the Xeljanz, right? Or they may go to something like this, okay? So biological response modifiers are meds that boost your immune system so that it works better. So if I can boost my immune system, my goal is to decrease or, right, limit those little immune complexes that are floating around, okay? So that's all biological response modifiers do. They just boost the immune system, okay? Did you have these meds down, TNFs? Yep, they're a type of biological response modifier. But you know what? When they get to these, they've tried pretty much everything, okay? So your Enbrel, your Remicade, your Humira, some of these, my sister-in-law, they wanted her to put her on Simponi, so we had a long discussion about this medication. Extremely expensive, thousands of dollars a month. She said, I think she told me it was $6,000 a month. She says, I can't afford that, Paula. And I said, well, here's some resources for you to see if you can get help with it, because she does have the nodules, like just her arms, her fingers, everywhere. And so basically, tumor necrosis factor is just another substance in the body that causes inflammation. So what these tumor necrosis factor medications do is they try to block that. And if I block that, I'm decreasing the inflammation, right? And isn't inflammation what starts this whole process, right? The inflammation is what causes the joint pain, the joint swelling. Long-term inflammation causes anemia. Over time, that pannus starts to form, starts to destroy the bone. So if I can try to stop it here, right? Maybe I can prevent destruction. So anyway, that's what they tend to do. There's a lot of side effects to these medications. Some of them are not really good, like heart failure. Okay. The other thing is some of them, the Remicade, that has to be given IV. So there has to be a lot of thought into these medications. There has to be a lot of discussion in relationship to, am I going to put my patient on this medication? Some of them affect kidney function. So I have to be concerned about the kidneys and evaluate the kidneys. If they're given by injection, I have to worry about that, because I know the Humira is given subcutaneously every 2 weeks. And a lot of patients do have injection site reactions when they get this. It tends to decrease over time, but they get that. So these are usually given, most of these are given IV or sub-Q. Versus orally, so that needs to be a consideration, okay? All right, meds. All right, so people, on the rest of your sheet, what did you put for nursing interventions? What did you put for nursing interventions? Pardon me? Well, that's not a nursing intervention. Okay, physical therapy is huge, right? We need to have physical therapy involved, because basically what we need to do is we need to evaluate where these people are, right? So physical therapy, and who else needs to be involved besides PT? OT. So I look at my fingers. How do I eat? What do I need to do? What can you modify? What can you help me with at home, right? OT is looking more at like the home environment, how to eat or do things, where physical therapy is looking at your mobility. So you need a PT, OT, okay? What else?
Nutrition.
Okay, nutrition. They're not going to feel good. They have a chronic inflammation going on. They don't feel good. They're not eating. I got to worry about weight loss, right? I got to worry about weight loss. Now, if they're very overweight, weight loss is good, right? Because it's less stress on the joints. But if they're not, what do I got to worry about, right? Nutrition, okay? What else?
Stop smoking.
Smoking, okay.
Joint protection.
Protection. Here we go. Joint protection. When would I use ice and when would I use heat? What's used for stiffness? Heat is used for chronic stiffness, absolutely. Absolutely. So heat is going to be used for stiffness, where cold is going to be used during periods of inflammation or an exacerbation. So when you have a flare-up is when you're going to use the ice, And when you just have this, I'm just really stiff and it aches and it hurts, then I'm going to use the heat, okay? Now, when you're thinking about joint protection, as Kyle said, what do I mean by joint protection? What would you tell me as a patient? How am I going to protect my joints? No jumping jacks. I can't do them now, and I don't have rheumatoid arthritis. That'd be a joke.
Like a brace.
Okay.
Balancing rest and activity.
Okay, balance, rest, and activity. Try to maintain a joint in a neutral position so it doesn't kind of, keep it neutral. Don't sit there like this for 24 hours. You watch TV as a kid and then you go to move and you're like, oh my gosh, my hand hurts so bad I can't move it. Did you ever do that? We did. Not when we grew up in a different era than you do. Use the strongest joint for any task. So for instance, if I'm going to carry or lift something and my fingers aren't very strong, do you think I'm going to use my fingers? Okay, so instead of using my fingers like for a laundry basket, how am I going to lift it? With my arms. That's what we're talking about. Okay, that's what we're talking about with joint protection. So you want to distribute the weight evenly. Don't try to pick up objects because I'm putting more stress on certain joints. You need to do something, try to slide it versus trying to pick something up. If you do have to pick something up, don't hold it way out here, right? I don't have a good center of gravity, so hold it closest to you. That's what I'm talking about with joint protection, okay? Be careful with repetitive motion, like a lot of the elderly women like to sew, knit, crochet, do things with your hands. Don't do those for long periods of time, okay? Because that just causes a lot of issues. You already understand the braces and the splints, right? Correct? All right. Nursing assessment, we're later. Here's some of the other things that you need to look at related to nursing interventions, okay? So we're going to talk about the... All right, lupus is another autoimmune disease process, okay? This is a progressive disease. So systemic lupus erythematosus, LSE for short, if you don't mind, because that's a mouthful after day 4. We're all going to be saying words today that we probably don't normally say because you're just getting tired. But this is a chronic progressive inflammatory disorder.
This one
Thank you. It's a chronic inflammatory autoimmune disorder, and it is progressive. And again, they really don't truly understand exactly what is happening in the body, hence we're back to autoimmune as the cause of systemic lupus. So basically, anything that is autoimmune, auto means against, correct? And so your body is attacking itself. Now, lupus is very difficult to diagnose, okay? So if you kind of look at some of the signs and symptoms that we're going to look at, in a little bit, you're going to see why. So all of these are really kind of hard to diagnose. And so what they have to do when you go to the doctor is they do what's called a differential diagnosis. So they're trying to say, do you have lupus? Do you have rheumatoid? Do you have some other kind of arthritic thing that I don't even know what it is, right? So they're trying to look at different things like that in relationship to what's going on. So basically, when you look at, causes and things like that, the evidence-based practice out there says that there is no single gene, because having like a defective gene was kind of a thought, but the evidence-based practice says there is no single gene that is out there, okay, that predisposes someone to lupus. I always have to read the evidence-based practice because otherwise... Rather, research suggests that a number of different genes are involved in determining the person's likelihood to get the disease, okay? So, I don't know what those genes are. That's for the research and for the researchers that are out there. But there is a genetic predisposition, right, to lupus. So, genetics does play a role. If somebody in the family has it, okay? And in your book, again, I apologize, I have the new edition. But on page 539, it also shows that it's a multi-system disorder, just like rheumatoid arthritis. So think about it. If rheumatoid can affect all the body systems and so can lupus, it's kind of hard to diagnose, right? That's why the ANA, you know, is an okay test to start with, right? Because they're saying, hey, there's something going on here. Now we've got to be a little more specific and do some other testing to try to figure out what this actually is and which disease process it actually is. So it damages your connective tissues. It can damage your blood vessels, your mucous membranes, etc. Usually it's the skin. In lupus, the skin is affected. Your joints are affected. And kidney is huge with lupus, all right? For some reason, these immune complexes that form with autoimmune. So when you have an autoimmune disease, right, it's an antigen-antibody reaction. And the antigen and antibody connect and form a complex. And those complexes float around, and that's what causes the problems. For some reason, they don't know why, but these complexes have an affinity for the kidney. They love visiting the kidney. And so the major cause of death in people with lupus is what's called lupus nephritis. And basically that means kidney failure related to lupus, okay? And you've already had kidney failure, so I'm not going to spend tons of time on kidney failure. There's many things, too, that can precipitate or exacerbate lupus. And so there's a lot of environmental triggers out there, especially sunlight. There's also medications that can exacerbate this disease process. And it's interesting because anti-seizure medications are one of the medications that can actually exacerbate this disease process. So that's why you always have to think about what's going on with this patient in totality, right? Because if you have somebody with lupus and they have a history of seizures, then you need to think about, what am I going to teach this patient? Or I need to make sure I teach this patient that, you know, this may cause you to have an exacerbation of your disease if you're on this medicine, and this is what you need to do to prevent that, okay? Other medications like apresilene. What do we use apresilene for? Blood pressure, right? Right? So we actually use it a lot when a person's blood pressure, they're on blood pressure medications and they're in the hospital and their blood pressure continues to, you know, go up. Apresilene IV, okay, or labetalol or Trandate is another med that they tend to use. Which one works better? I can't tell you, because I do know that in some patients when we gave Trandate it worked great, and others it didn't budge it at all, but apresilene did, okay? So again, that's evaluating, is this working or is this not working? It's not working, what else am I going to do to help this patient? Okay, so those are things that can help exacerbate this disease process, all right? All right, pathophys, my people. Okay, it's too hot in here. Pathophys, isn't it warm in here today? It's suffocating. All right, where's my lupus bags? I don't mean your bag, really, but where's my bag, ladies? Okay, so in a nutshell, what would you say? Because, I mean, you know, lupus, when you look at patho, you can look up patho in a book. You can look it up online, and you get about this much. Okay, there's not a whole lot because guess what? They really don't know what's going on. Okay, so what do you think for patho? In your own words, what'd you guys come up with?
Antibodies are formed to parts of the nucleus in the immune system that forms immune complexes, and then they are deposited into areas of the body like the kidneys, the heart, brain, joints, skin, and it causes inflammation and damage to the organ.
Yep. Yep. Good. Very good. Okay. And look at all the things that can be affected. Okay. And you know, I'm not going to sit up here and tell you, okay, if the lungs involved, this is the signs and symptoms you would see, because should you not know that already? Right? Do you understand what I'm saying? So you already know that already. You know, so you look at your little book, and it tells you all the different things that can happen in the cardiopulmonary system, right? So, think about it. If you have this immune complex in your lung, what do you think your body's going to do? What would you see in your patient? Okay, sure. Okay, shortness of breath, maybe some secretions.
Lower blood concentration.
Okay, potentially for a lower O2 sat.
Diminished.
Okay, all right. Maybe diminished breath sounds. Okay, elevated respiratory rate, right? Right, elevated respiratory rate. Okay, so tachypnea, because that doesn't belong in there. Okay, if you have something that doesn't belong someplace, your body, your organs try to say, I don't want you here. So what am I going to do? I'm going to cough. Okay, I'm going to cough to try to get rid of it. I'm not able to breathe very well, so I'm going to increase my respiratory rate, right, to try to get more oxygen. All right, so those are just a few of the things that you're going to see. So basically what's going to happen is like we said, we're going to have antibodies, right? So we're going to have antibodies that are formed, but these antibodies are called what kind of antibodies? Auto, because they're against, okay? They're not sure what starts this whole process, but anyway, we have auto antibodies that are formed, and those auto antibodies affect the DNA or the nucleus of the cell. And think about what happens when we affect the nucleus of the cell. What happens? What happens to the cell? Nothing? Okay. Yeah, the cell isn't going to function correctly, right? Hence, we have, what did you say later on? Organ damage, right? Organ damage. So these auto antibodies don't belong there. So auto means against. So we have an antigen-antibody reaction occurring again, and we get these immune complexes that form. These immune complexes, we don't know why they go where they go. And in some people, they may go to the lung, and in other people, they may not. We have no idea, okay, why they go to what organs they go to. But what you need to understand is they don't belong there. So your body's response to that initially is inflammation, right? So the body's response initially is this inflammation, okay? So you get this inflammation, and then eventually, depending on where they go in the body, you start getting some issues with organ problems, okay? Because remember, it's affecting the cell nucleus or the cell. Remember, your tissues are, you've got cells, right? You've got tissues, you've got organs, and you've got you. So when cells start to be affected, then the tissue starts to be affected, then the organs start to not function well, and then the person doesn't function well, okay? Does that make sense? So that's kind of what you have to think about when you think about the pathophys. So I'm not going to sit here today and go through every body system that can be affected. You need to do that. All right, you already know the lungs, right? You already know, you've already had all the body systems in some form, right? So you need to look at, when you study, what would happen in this patient. So for instance, let's say they affect the blood vessels, okay? They call that vasculitis, right? So that's inflammation of the blood vessels. So if my blood vessels become inflamed, what's the main thing that's going to happen? What? What did we say? Yeah, decreased circulation, right? Because inflammation causes swelling, correct? So we're going to narrow the blood flow wherever that's at. And so basically we're going to deprive that organ of arterial blood and hence oxygen, right? Because your oxygen's carried in the arterial system. So then you say to yourself, what do you assess on that patient, right? What do you assess on that patient? Do you see what I'm doing? So I'm not memorizing, I'm not sitting here saying, okay, they're going to have vasculitis, they're going to have pericarditis, they're going to have this, they're going to have that. I'm saying to myself, okay, if they do get pericarditis, like we said the other day, right, that's inflammation of the pericardium around the heart. It only stretches so far, right? Just like a balloon, it only stretches so far. And when that fills up, the only other place it has to go is inward. So the pressure pushes on my heart. So instead of my heart doing this, my heart might be doing this. So I may have severe, decreased cardiac output. And as I said, the only function of the heart is to pump. But it's a very critical function, right? And so if I have decreased cardiac output, it's going to affect every body system, right? It's going to affect every single body system, okay? So that's kind of what you have to think about. And as I said, these immune complexes love the kidney. They're attracted for some reason to the glomeruli. And so many of these patients will have some form of kidney involvement. And the main cause of death is that lupus nephritis. So if you have a patient in, let's say, the hospital, I'm just going to do pneumonia. I don't know why I have pneumonia on the brain, but they have a history of lupus, okay? So what do you need to think about as an intervention for that patient? When you think about the kidneys being involved. Okay, well, what do you want to do as a nursing intervention? Nursing interventions. Okay. What's their urine output? Right? Because I want to know that. Because I want to know if the kidneys are being affected, right? So we need at least 30 mLs per hour minimum, right? And so it's about 400 cc's in a 24-hour for your body to rid itself of all the waste products and stuff that shouldn't be floating around in there, all right? Otherwise, you're going to get sick, right? Because what happens to people with renal failure? They get sick, don't they? They get sick because we have all this toxic stuff floating around in there and our electrolytes are all messed up. So see what I'm saying? So when you study, you're going to say, okay, this person could have cardiac problems. So what do I need to think about with this person if they have some cardiopulmonary problems, right? What am I going to assess in this patient? Do you see what I'm saying? Okay. What is their heart rate? Correct? What, is it regular? Is it irregular? Are they on tele? If they're on tele, what is their tele showing? Because if you have an irregular heartbeat, that heart is upset about something. All right, something's going on, either electrical conduction and or mechanical, which is pump. Okay, so that's what the heart is. It's a mechanical, which is the pump, or it's electrical. Now, the electrical conduction system needs oxygen to work correctly. So if you're oxygen deprived, think about vasculitis. I think to myself, well, if that happened in the heart, wow, there's a lot of things that could happen to this patient, huh? So you see how I'm thinking? That's how you have to think. It's no longer just memorizing and regurgitating. And you know what? What happens to one person may not be the same with somebody else. So everybody's going to respond differently, which is why it's critical for you to understand and why we're going to push you clinically to understand not only the main disease process, but how everything else, right, that they may have as comorbidities is impacting what's going on. So yeah, I'm going to worry about breath sounds and color and O2 sats and do they have respiratory treatments and, are they short of breath? Do I need to blah, 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 blah with pneumonia? But they're in here with lupus too. So now I've got to think about, okay, are they on tele? What's their heart doing? What's their intake and output doing? Do you see what I'm saying? That's what you need to learn in 250. All right, that's what we're talking about when we talk about putting it all together and understanding what's going on with your patient. Does that make sense? It's not worrying about doing Foleys and doing dressing changes and all that kind of stuff. That's not a focus for me. Everybody says, well, I haven't done any Foleys. Well, you know what? I graduated from nursing school, never put a Foley and worked a urology floor when I first graduated. So, you know what? Foley City once I got out there. Bottom line is, I would say, what I said in my interview is, I'd be more than happy to work the urology floor. However, what kind of orientation program do you have here? Because in my educational program, clinically, I never got the opportunity to actually put a Foley in a patient. I did it in the simulated lab, but not in the patient, okay? And that's okay, because nowadays, you don't do a lot of things like you used to years ago. Seldom do you get an IM injection, right? Seldom do you do that now. So, so think about in totality. That's what we're trying to get you to do, is think in totality about these patients, okay? All right, so let's look at symptoms that this patient may have. Okay, there's a lot of symptoms that you see with these patients, okay? And I'm going to tell you this. It's very hard for me to stand up here and describe for you what a typical SLE patient looks like, because it's multi-system and everybody is affected differently. Now, I could stand up here and talk to you about a CHF patient, right? I could stand up here and talk to you about a hepatitis B patient. I can stand up here and talk to you about a cardiomyopathy patient and what they will look like. I can't do that with lupus, okay? I can't do that with lupus because of the extreme range of symptoms that you're gonna see. So there is really no classic presentation, with these patients. So when you look at this person, what are you gonna see? I mean, what kinds of things did you guys have that neuro-wise they should be okay, right? We're hoping neurologically they're okay. So neuro, all right. So if you look at neuro, I'm just gonna put okay, all right. Neuro, let's do cardiac, okay. So I'm not doing focused, I'm doing more like just a head to toe kind of thing. What would you think about with cardiac? What did I say? The electrical conduction system needed and plus the mechanical needed. Okay, so if they don't have O2, what may they have? Okay, I'm just going to put EKG changes. It's easier to spell. Okay, EKG changes, right, versus dysrhythmia. Now, I will tell you, if they have EKG changes and they start to have cardiac problems, it usually indicates advanced disease, all right? So it usually means this disease has progressed and it's pretty much advanced. So it means advanced disease, okay? The most common thing you're going to see in patients with cardiac is pericarditis. Okay, and we just talked about that, right? Have you heard of cardiac tamponade? Yes? No? Don't remember it because you didn't walk when you were learning? Why do you think I walk when I lecture? Yeah, I think better. Seriously. That's why I gotta walk around, okay? Might break my ankle, but that's okay. Poor Chris Orange, got a big old cast on it. Green one, yay, go green. Anyway, she sent me a picture yesterday. She said, oh my God. She said, it won't take long to come off. Anyway, so pericarditis. What's cardiac tamponade? Fluid around the heart. And so if I have fluid around the heart, what's what's happening to my heart? It's compressing my heart and I have decreased cardiac output, okay? So pericarditis is one of the most common things that you're going to see. And the other thing that you tend to see is with respiratory, okay? So what did we say happens with respiratory? We have an elevated respiratory rate, right? Person may cough, just like somebody in the back room just coughed. Where are they? We're going to assess you. Who's coughing? They don't want to admit it now. Like, you keep your hands off me, old lady. Okay, right? Okay, so we want to check their O2 sats. We want to check their color. We want to check their breath sounds, right? Right? And with cough, you always want to say, is it productive or non-productive, right? Is it dry? Is it hacky? You always want to describe anything, okay? Because if you put patient, cough, what's that mean to me? It means nothing to me. I don't know what cough means. You just coughed. I don't know so you coughed. Did you cough because you were aspirating your drink? Did you cough just because you had a tickle in your throat? Is this a chronic cough? How do I know? Okay. So those are some of the things that you're going to see. And one of the main things that you tend to see is pleuritis. What's that? Right, which is what? The membrane around the lung, right? Okay? The membrane around the lung. So yeah, the person's going to cough, and yeah, the person's breath sounds maybe diminish, that kind of thing. Okay? So you're going to start seeing things like that in patients with respiratory. All right? So what else do we look at? What else do they have? What else was in your bag with cardiac that they can have? If it causes vasculitis, what else can these people have?
High blood pressure.
Raynaud's. Thank you. Raynaud's. Even though we had it with what disease? Yep. We can also have it with this now. See what I mean? Why it's hard to diagnose? So what if they present with Raynaud's? What's causing the Raynaud's? Okay. Do they have lupus? Do they have scleroderma? Do they have whatever? I don't know. Okay. So again, vasculitis, right? Vasculitis, inflammation. And so that can affect, I could you have this. So that can affect that person too, okay? So that's what we look at, some of the things we look at with respiratory, okay? So cardiac, respiratory, anything major with GI. Did you have anything major with GI? Probably not, okay? Nothing major with GI really. But again, remember, the GI tract is a muscle. So we still need oxygen, correct? So I would still check bowel sounds, right? Distension, but you don't normally see in the literature more than like the, abdominal distension, maybe some belly pain, occasionally some nausea and vomiting. So your typical things that you would see with GI, okay? So GI, and then we go to renal. Okay, I made that big because that's the most common cause of death. So then we go to renal, okay? And what we really want to do with these people with lupus is we want to do something to prevent this, to slow the progression, okay? That's what we need to do, because what are you going to see with people with renal? I think your book says, I don't know the exact number, but I think your book said something like, was it 75% of patients with lupus will have some form of renal involvement. That's huge. That's a huge number, okay? So about 75% of these people will have some kind of renal involvement, and the renal involvement can occur within a couple of years. So it doesn't take long for that to start to happen. So they're going to do some things to try to preserve the renal function on these patients. So our goal is to try to prevent this from happening if we can, okay? So basically they're going to give them medications that we'll talk about in a little bit. So if they have an exacerbation of the lupus, one of the things they're going to put them on is corticosteroids, right? And so corticosteroids hopefully will help calm the disease down and work a little bit with this. So I think your book talked a lot about corticosteroids in relationship to preserving renal function, okay? So renal is huge, all right? The other thing that we have to look at is neurocardiac, respiratory, GI, GU, right? This is GU. Okay, musculoskeletal. See, I'm doing head to toe. See what I'm doing? I'm thinking body systems. I'm thinking head to toe. What did you guys have for musculoskeletal? Joints, okay? Arthritis, okay? Now, just because you have arthritis doesn't mean you have lupus, all right? So I think approximately, and again, I'm not going to test you on percentage, but about 90, I don't know what your book said, maybe 90% of people with lupus have arthritis, because it affects the joints. So it's huge for people to have arthritis. The other thing, as you already said, you're going to have joint swelling, right? And pain, because remember, inflammation causes swelling, right? Swelling causes pain. So your typical signs and symptoms, of, so you got pain, swelling, right? Maybe some redness, correct? So that's because of the inflammatory process that's going on in these patients, okay? The other thing you have to think about with these patients, and that picture shows you, that's called what? Butterfly rash, okay? I think that's very interesting because they really can't tell you why that occurs, and that doesn't occur in everybody. That only occurs in about half of the people that have lupus, all right? I remember years ago, I'm talking years ago, like years and years ago, and I was working as an aide at the hospital, and this resident came up, and, I always have this red face, it's just my complexion. And he looked at me and he says, "Oh my gosh, you have a butterfly rash. You have lupus. I'll never forget that as long as I live." And I don't have lupus, so you need to go back to med school because I do not have lupus, and you would never tell anybody that. Number two, I'll never forget that. He did. He said, "Oh my God, you got a butterfly rash on your face." I'm like, "Look again, buddy." Okay, and I look again. Let's do a better assessment. I don't know where you went to school, but don't come to me. Okay, so butterfly rash. All right. On the bridge of the nose, so you can see it does look like a butterfly, doesn't it? Like that's the body and that's the wings. So that's something that you can see that's characteristic of someone with lupus, okay? Now remember, it can go anywhere in the body, and it can affect the blood vessels, right, and cause vasculitis, hence I can lose my hair. So alopecia could be a problem with these patients, all right? So there's all kinds of things that can happen, but this sort of is like, so you see what I'm saying? I don't know how to tell you what this patient's going to look like because I don't know what this patient's going to look like. So that's why you have to look at all the signs and symptoms that are happening in this patient and, go from there. Now they have neurological, I put neurological on here, but normally in a patient with SLE, you don't see neuro things. What you tend to see is your renal issues, and they will put them on a medication early on to help prevent that. Okay, the problem is one of the medications they put them on can cause other serious problems, so you're kind of like, I don't know what's going on. All right, hematological. So here you go again. Those complexes can affect, right, the bone marrow, can affect my body's ability for those stem cells to produce new cells when your body needs it. Because your red blood cells only live, 120 days? I would just say 3 months, I don't know. They don't live long. And so but your body knows to replace them, okay? Your body knows to replace them. And so what happens then in here is you're going to start seeing two, because this is what kind of disease? It causes chronic inflammation, and inflammation is going to impact your hematological system. So now I got to worry about, bruising, bleeding. Do you see how I'm thinking? I'm not sitting here memorizing, okay, thrombocytopenia, leukopenia, and anemia, because you'll never get it, and you'll struggle. So what you need to say is, the red blood cell count can be low, so then I need to worry about, quote unquote anemia, but I need to worry about, are they fatigued? So cluster your care, right? Do things like that. What is their hemoglobin? Are they symptomatic with the hemoglobin at that? Because, they used to always do transfusions when patients were at 8. Now the standard is 7, unless they're symptomatic, okay? So that's why you want to look at trends when you look at labs, because you're not always going to call the doctor right away because something is low. So you want to just think about, okay, the patient is anemic. What am I going to do? The patient's white blood cell count is low. What do I need to worry about? Right? I need to worry about infection. So what am I going to look at when I worry about infection? The patient's platelet counts are low. I got to worry about bleeding. Then you've got to think about the medications that they're on, and is the medications going to do anything to any of this? And then they're on a lot of corticosteroids because we use it for acute exacerbations, and then obviously we worry about infections and wound healing and blood sugars and osteoporosis and all that good stuff, right? So you see how I'm thinking? I'm going to keep saying that all semester because I want you not to memorize. I want you to think, okay?
Serum creatinine goes up just for the fact that the kidneys aren't able to filter it then. This is exaggerated or...
Exacerbation?
Yeah.
It doesn't necessarily have to go up.
But it can though.
Oh, yeah, when you have it, well, it depends on if the kidneys have been affected.
Right.
If the kidneys have been affected, the creatinine will go up, but I don't know what it will go to because I don't know how affected the kidneys are.
Okay.
So, they're going to do baseline BUN and creatinines on these people.
So that'll be a later sign though, the creatinine jump.
Yeah, usually, well, as I said, like it says, you can have renal involvement within the first year or two.
Right.
So all they're going to do is monitor it, right, and it depends on how it affects that patient. So BUN and creatinine, especially your creatinine, because BUN in and of itself isn't truly just renal, okay? Creatinine is the only time a creatinine rises is with kidney problems.
Right.
It's the only time it will be elevated. So that ought to be a no-brainer lab, right? Creatinine elevated, think renal, okay? Okay? Yes?
So can't they
also have problems with forming clots on the other side of that, because in the book it said that sometimes they have to be put like on warfarin, or, I mean, so it's not just like bleeding.
Right, because why would you think clots would form? What do you think's going on in the body?
Destruction of the platelets.
Okay,
Not working
well,
properly.
destruction of the platelets would make you bleed.
Oh,
So what's going on in the body? The vasculitis or vasospasms, right?
okay.
So vasculitis, swelling, right? So instead of my blood vessel being nice like this and everything flows through, I might have some swelling here, stick, right? As it tries to go through, it gets stuck. The highway gets blocked and now it's hitting here and sticking instead of going through. And you can have clots. Yeah, well, so think about that.
Oh, yeah, either way.
So either way, okay? So it's an issue either way. But that's what I'm saying. That's why it's so hard for me to sit here and say to you, this is how this patient is going to present. I can't do that, all right? That's why you really need to, look at that patient themselves and what's going on with that patient. So if you know they have a definitive diagnosis of lupus, these are just things you need to think about, right, with this patient. So these are just some of the signs and symptoms that they can have in relationship to lupus, okay? And so this is a little picture. Do you have this? Okay. So this is just nice because it puts it together in pictures that you can understand versus mine. And again, they're very photosensitive, and that's something we're going to talk about in a second. Photosensitivity is huge. Fever is the classic sign of an exacerbation of lupus, right? Because it's an inflammatory reaction. So fever is a classic sign of a flare-up. And they can have just general weakness. They can have general fatigue. But when the fever goes up, it means exacerbation. But the other thing I need to think about is not just exacerbation, but do they have an infection or something going on now too, right? Because they can be leukopenic. So I need to think about that. So this is just to kind of put it in a nutshell for you, just some of the things, that we just talked about. So if I could draw, that's what I would have done instead. There's my drawing. You got it. That's what you, okay? This is in your textbook. I just took it from your textbook. Again, this is why it's very hard for me to say that there is a classic picture of somebody that has lupus. What is it in the old book, Kyle? 1583. 1583 and version, I don't know what you have. Version 9, I think it is, and version 10, it's on page 1539. Okay? So what about labs? Talk about these labs. What did we say the issue with an ANA was?
Across the board.
Yeah, it can be something else. So it's not specific to lupus, but it may be a start, right? And if the ANA titer is up, then that will say, okay, now we've got to break this down, right? And we got to try to figure out why. So what's going on with this person? What else might be elevated, and what's happening, and why is it happening? Okay. Now remember, somebody said it affects the DNA, right? So do you see these? Okay. These are different against the antibody, right? So against means these are more like an antigen, so to speak, right? So it's an anti-DNA or an anti-dsDNA. Basically, the anti-DNA antibody is the more specific indicator of lupus because you rarely find that in anything else, okay? So this tends to be more specific for lupus, although this will be a starting point, okay?
They have, I know, they have a rheumatoid factor, they have a lupus factor they can look for the immune complex.
They don't necessarily have what we call a lupus factor. So all they have are these right here, okay? All they have are these three right here, that they do not have a lupus factor. Now that would be great. Maybe you should research that. See, maybe you should become a scientist and find that lupus factor for us, Sherry. So anyway, the anti-DNA, because remember it affects the DNA of the cell. And so this tends to be more specific because these antibodies are rarely found in any other disorder. So that would be a specific lab. the anti-dsDNA that's on there, all that means is double-stranded. And again, these are found in people with lupus, but, bless you, but it's only found in about 50 or 60% of the people, okay? So again, nothing is necessarily found in everybody. So that's what makes it really hard. Why do some people have an elevated rheumatoid factor with rheumatoid arthritis and other people don't, and they have it? Who knows? That's why you always start out right here. History and physical, head to toe. They're looking at what are some predisposing factors, you know, that may lead you to have this disease process. Talk to me. Okay, they'll do this to try to help with a differential diagnosis. Because if this isn't elevated, they're probably not going to go the lupus and our rheumatoid arthritis. Okay, so this is a starting point. But this is the most specific. This is just another antibody, or an anti-antibody, I should say, that forms, but it's only in about half of the people. However, one of the things the research has found was that if people are positive for this anti-dsDNA, they have some form of renal involvement. So the research has found that the presence of that dsDNA often suggests more serious lupus, and it usually says this person has some form of renal involvement, okay? And this anti-SM antibody, they usually don't even draw it. It is found in the nucleus of the cell. It is usually only found in people with lupus. But again, these tests aren't cheap. And research shows that only 10 or 20% of the people are going to be positive for this. So this probably isn't the one to start with, right? Because that leaves a lot of people that are out here that we're missing and could miss a diagnosis if we just did that, okay? All right, so anyway, what's antiphospholipid? What's your book talk about that? What is that for? Yeah, what it indicates a coagulation disorder, okay? So basically, this is something they look for because this actually is a disorder. It's called antiphospholipid syndrome. And what it does, this antiphospholipid, is it attacks proteins in the blood. Okay, so it attacks proteins in the blood, and it can cause blood clots. So hence, again, Angela, that's another reason for clots. Okay? Or Andrea, I mean, I don't know why I called you Angela. I was thinking of somebody. It's okay, yeah, thank you, because, you know, it's Thursday. We're all tired. Right? Okay, so does that make sense? So then this is why you may see them, and sometimes they actually call this in the literature lupus anticoagulant. All right. ESR, CRP, we understand, correct? Okay. ESR, CRP makes sense. It just means what? Okay. Now these are other tests that I'm not going to go through all of these tests because remember serum complement levels. Serum complement is a group of proteins that help, right, deal with an infection. But if you have a chronic inflammation, all those proteins that are in that complement that are coming to try to help decrease because of chronic inflammation, because your body's using them up. Okay, your body's using them up. So when they do this serum complement panel, and it's not just one thing, it's a whole bunch of stuff. And if you never see it, it's too much to worry about until we see it. But you're going to find that that is going to be decreased. Okay. The other things are just some of the things that they're going to look at based on body systems, right? You have cardiac enzymes, liver enzymes, renal function tests. So they're just going to run these different kinds of tests to try to figure out where the patient is at, right? Where's the baseline for this patient? That's what we're trying to find out, okay? Does that make sense? We good with that? Okay. All right, diagnostic tests, huh? Do they make sense? I'm not going to read through all of these because, you know, these are things they're diagnostic, right? They're going to do an echocardiogram because they're trying to find out what's going on in the heart. Is it really something structural, or is it something else going on, right? Because an echo looks at the heart size, the heart structure, right? Can look at wall motion, those kinds of things. So we're just doing these different kinds of tests to, and they do them to give you a baseline. And that's what your assessment ought to be on your patient in the morning, hence you do a head to toe, because that's a baseline. All right. And then when you go back the second time, you normally just do more of a focused assessment. But when you're talking to the patient, if they start to say, yeah, I'm getting this really bad headache I never had before, or whatever. Do you know what I'm saying? So, and remember what I said is don't put words in their mouth. Don't say, are you having blurred vision? Because what are they going to say? Yep. Oh, yeah, it's really bad today. What you're going to say is, are you having, how's your vision today? Do it more general. Don't put the signs and symptoms in their mouth, because they're going to say yes. Okay? How are you doing getting up? And then that gives them a whole window to say, well, you know what, it's really hard for me to get up, it really hurts, but once I'm up for X period of time, I seem to do better. Do you know what I'm saying? So when you're doing your assessments, don't go in there and give them the signs and symptoms you want them to have, because they should have it with the disease process. Be more general in your assessment so they can tell you, all right? Because then it's going to be accurate. Because you tell somebody and they're going to agree with you, especially if they don't know you or they don't understand what's going on. Yep, I got that, okay? All right, so what are we going to do? Again, I want to maintain that person's life. I want to prevent end organ damage, okay? I want my organs to work is what I want them to do, correct? I don't need organ dysfunction or organ failure. So basically our goal is to try to prevent that, hence preventing a lot of the signs and symptoms that we're having, a lot of the long-term complications that these patients can have. That's what we're trying to do for these patients, okay? Meds. I'm not even going to talk about corticosteroids, okay? You know about corticosteroids, correct? Okay, exacerbation. That's how you say it, exacerbation. It is a flare-up. We already talked about corticosteroids, why we give them, correct? Why we don't want to give them, right? Because of all the long-term side effects, right? But monitor their blood sugar levels, right? Especially, that's one thing you can do. NSAIDs we already talked about. That's for minor problems, okay? That's for minor aches and pains. It's nothing huge, okay? But here's the huge med that they use right here, Plaquenil, okay? Hydroxychloroquine, or Plaquenil, is called a DMARD. A DMARD means disease, and this is in your book. You don't have to write what I say. Disease-modifying anti-rheumatic drug, okay? Disease-modifying anti-rheumatic drug. And so this is a medication that they tend to give to people. But the problem with it is that it can cause visual problems. It can cause that blurred vision. So if you say to your patient, are you having blurred vision today? They're going to say yes. And maybe they aren't having that. So you need to ask them, how is your vision today or whatever. But then you need to make sure in your teaching for that patient, right? You think about safety if they have blurred vision. Number 2, they need frequent eye exams, all right, every 6 months to 1 year, so that they can follow up, because those complexes can affect the eye, right? The vision, the retina. So they can affect the eye, etc. And the other thing is those medications can affect the kidney. Well, what do I do? Because one of the things I'm already worried about is renal problems. But what do? This med works really well on these patients. Okay, this tends to be the med that they put them on out of all the different medications that are out there. It's also called an anti-malarial medication. So, but this is really helpful in treating lupus, especially like joint symptoms too that don't respond to other kinds of medication. So that is an important medication. Okay, very used medication. Immunosuppressants do what? Suppress the immune system. Now, we're not going to give these to them routinely. Immunosuppressant drugs are reserved for the patient who has a severe form of SLE, and they have not responded to any other kinds of therapy. All right? So immunosuppressants, All right, they sometimes are used with people with renal problems too, but they're not just going to put them on these and keep them on forever. They like to put them on this if they have severe form of lupus. Okay, so, and I know that because everything else I've done, they've not responded to, right? So then I know their lupus is bad. Because what do immunosuppressants do? Suppress the immune system, right? And if they suppress the immune system, then what happens? Now I got to worry about infection, right? So here I already have all these problems going on. Now you're giving me, now I have infections going on, right? So I'm just complicating the problem, okay? Anyway, so this is evidence-based practice, CELSUP. That's evidence-based practice. So you guys think it has to be something huge out there and you freak out about what it is. Basically, they have found that helps prevent, basically, and or reverse this lupus nephritis, okay? So if a patient does have elevated creatinines and BUNs, they're probably going to keep them on the CELSUP, all right, for the kidney function. But then you've got to be careful and teach them, right? Avoid crowds, wash your hands, you know, all that stuff that you learned about preventing infection, okay? Now, what did I say biological response modifiers do? Thank you. They boost the immune system, okay? All right, so this one I could never figure out how to pronounce. Anybody want to help me with this one? Mumab, okay? We're learning all of these together. See, but you notice what they end in? Mab. Okay, so just keep that in your head. Rituximab, I got that one figured out, or Rituxan, I had that one figured out, but the other one I'm like, oh, tongue-tied. So basically, the FDA actually has just recently approved this first one, okay, for the treatment of the signs and symptoms of lupus. And what it does is it basically inhibits a substance that causes the B cells to be produced, right? And because remember, your body is attacking itself. So these antibodies are attacking your body. So what it's going to do is it's going to inhibit a substance in the body that causes the B cells to attack your body. Okay, so attack yourself, attack the body. That's recently been approved. Okay, so what it does is it's halting the progression. I don't even know. I need to take a nap. The production of those antibodies. Okay, so if I am trying to, right, because this is what's happening to those antibodies in the body. They're not good antibodies anymore. They're bad antibodies. So what this drug is trying to do is halt the production of these bad antibodies, thus decreasing the symptoms of the disease process. So this one was just recently approved by the FDA. So that's a newer medication that's out there, okay? So there is some things. Lupus nephritis, not going to talk about it. You've already had dialysis, correct? So you know that there's peritoneal dialysis, there's hemodialysis, right? We know about fistulas. We know about all that good stuff, correct? Okay. Nursing assessment, head to toe. You always know, I don't put everything on here at senior level, okay? Because you should know some of this stuff by now. Vital signs, TRABs. Here's some of your nursing interventions, but these are just global nursing interventions. Why don't I put it that way? All right. But your nursing interventions are going to be dependent on what you're going to see in your patient. Okay. But these are global things that you need to think about in these patients, right? Monitor labs and all that good stuff, right? Monitor for adverse effects. Okay, skin protection is very important because these people are photosensitive. And when I say photosensitive, what do I mean? Okay, the sunlight bothers them, okay? So they need to avoid sun exposure because it can cause an exacerbation of the disease process. So what kinds of things are you going to teach them besides the sun blocking agent? Hats, maybe. Stay out of the sun, sit in the shade, hats, long sleeves. Yeah, just what we need. It's 95 degrees out, long sleeves, yay. You know, right. I'm dying in here at 70.
They have those long sleeves that are super breathable.
Do they?
My mom has to wear it because they're testing her for lupus.
Are they? So where do you get them? Like what do you mean? They're just,
We only found them when we went to Florida.
okay, of course. Okay, we're making everybody, we're going to Florida next week, no test. We're gonna go look at clothing down in Florida, so bring some back, okay? We could do that, wouldn't that be fun? Oh my God, that'd be a riot. I would love that. But you can't go to the Gulf Coast right now anyway because of the red tide, so, you know, yuck. My cousin's there, in fact, I was supposed to go, she tried to talk me into going. I mean, she's from Egypt and she moved to the States and I hadn't seen her in like 40 some years. And so like 3 years ago we went and it was Siesta Key was beautiful. So she sent me a message the other day. I'm really glad you didn't come because the dead fish all over the beach and it smelled so bad. They had to wear like masks to go outside. They couldn't even go in the pool in the place they were in because it stunk so bad. And I said, go to Captain Kirk's and eat. That was the best meal I ever had in Siesta Key. And all the restaurants we went to, she said, nobody's eating seafood down here. What's the matter with you? I never thought about that. She says, the parking lot's empty. So they're going to Italian Oven and all these different restaurants. You know, here you go down there because their seafood doesn't, you have a shrimp from Michigan and a shrimp from here, oh, that doesn't even taste the same, you know. So anyway, we'll all go down there and eat the seafood, right? Come back sick. So, okay. So anyway, so sunscreens and they, you know, I think the book says 15 or higher, but if I had somebody with lupus, like I burn with 70 on, okay? Literally. I mean, like somebody thought I had color. Well, that's just old age, not color, because you can even see the old age spots, the brown things. I have those. Let them see. If you don't believe me, they do come with time. But you got to put it in perspective. And I would say to the patient, you know, before you had lupus, what did you use? And did it help you? Do you see what I'm saying? I'm not just going to go in and say, use number 15. They're going to use 15 and fry. Okay, that'd be like a lobster, right? Well, maybe they need 70 protection or whatever. So anyway, these are just things that you need to think about in these patients. I always tell my patients, and dermatologists will tell you this too, and I know ladies, you're gonna go, ugh. You should not be going, and I'm not trying to have businesses closed, but you should not be using stuff with all these different perfumes in them. Bath and Body Works and all that stuff, they will tell you that's an absolute no because it is very irritating and harsh to the skin. So these people need to just buy something that's pretty clear, like CeraVe, Eucerin. You know, don't go buying Irish Spring soap because that can really irritate people's skin. So you want like Dove soap, stuff that doesn't have all this extra stuff in it because it can affect. Okay, so teaching, okay. Right? Medic alert. Maybe we need to think about a medic alert. The other thing you really need to teach them, and I don't even know if I have this on here, is I just think as I talk, how to recognize and prevent infection. To me, that's huge, right? How to recognize and prevent infection. I'm talking even good oral hygiene, right? I'm talking good body hygiene. Make sure you keep all your appointments, you know, your lab appointments, because we're monitoring their CBC count, right? Make sure you keep all your lab appointments. You know, if they're on immunosuppressive therapy because we have some kind of renal involvement, we really need to teach them, don't we? What to do with things like that. Does this make sense? Are we good with that? Okay, all right. So take a break, come back about 20 after, and we will start on oncology. Okay.